Another is megakaryocytic series. Of course, again then you have to see the budding of the megakaryocytes, the nuclear lobulations, because hyponucleations, loss of lobulation, these are the abnormalities which are seen in the megakaryocytes. But even in normal, I don't know, these have been highlighted, but even in normal smears also, or with no megakaryocytic lesion you are expecting, you see lots of variation in megakaryocytes. That is my experience. So you cannot, because mostly if you suspect something, there is in your mind something, you start seeing abnormalities. In person also. If you dislike me, you will see only concentrated on seeing my abnormalities rather than seeing my positive point. Isn't it? Same occurs in this also. So basically, whether this is a histology, cytology or anything, don't go, because I have seen. The clinician is writing malignancy in cytology, as you search for a single cell which is looking abnormal. Invariably, if you see, that is associated with inflammation. And in inflammatory, any inflammatory smear, if you start searching, you will definitely see abnormal cells which look like malignant. Don't rely on single cell. Same thing happens in bone marrow also. Okay? Now, as far as these are concerned, large number of megakaryocytes are particularly seen in ITP. Then idiopathic thromboasthenia or thrombocytosis and chronic myeloproliferative disorders. Polycythemia also, myelofibrosis and hypersplenism is a reactive. So all the elements which are deficient in this or being destroyed in the spleen, not necessarily all the elements will be destroyed in all the cases of hypersplenism. That's why it is a very difficult diagnosis. Now, every book, they describe that in idiopathic thrombocytopenia there is a different morphology. I could not find much difference in that, really speaking. So this is a essential thrombocytopenia or thrombocytopenia. We had a case, young patient, 18 year, in an engineering college, had bleeding from the gums. The cell counter refused to give the platelet count. On manual counting, it turned out to be almost 75 lakhs. And then this was successfully treated. That is the only, of course, as far as 4-5 lakh counts are concerned. Not that every patient of 5 lakhs or 7 lakh is a case of essential thrombocytopenia. Remember that. This count I have seen even in the patients undergoing chemotherapy. Maybe reactive, I don't know, because I don't have the real follow-up of those cases. After chemotherapy, many a times the count goes down. But before next chemotherapy, when the patients come, I have seen the thrombocyte count going up to 7.5 or 8 lakhs also. But this is my principle, that, patient is undergoing, so manipulate the report. I have seen many people, if the hemoglobin is 19 or 70, they give it, make it 15. So no questioning. Okay? I give it. And this is, I have found. So if it is a persistently increasing one, then diagnose this. Otherwise, no. No need to give any treatment. Then, yes, A megakaryocytosis or aplasia, like red cell aplasia, A granulocytosis, you can get aplasia of the megakaryocytes. This is again a rare condition. I have not seen a single case in my life up till now. This is a case of, we had a case of megakaryocytic leukemia, and that you will be seeing in details in the workshop. These are the different abnormalities, and you see this middle one. Now very difficult to differentiate from any giant cell, inflammatory giant cell. Even the multinucleated normoblasts also look like that. I had shown you the photographs in the previous erythroid series. Okay? And sometimes these are the ones which can be mistaken as macrophages in the bone marrow. So, whatever it is, can this be, if given a single cell to any expert in hematology, can he diagnose this as? No, I don't think. With my experience, it is not possible for anyone. With experience and with the background of the bone marrow aspiration, in which type of cases this has been done, you presume. That's what I think. I may be wrong. Okay? Again, bone marrow assessment, yes, I don't talk about this much, but this is particularly important not in leukemias and others, but myelodysplastic syndrome, particularly to show the sideroblasts as they are seen here, and in particularly anemias. Now, two things I have mostly realized, that in megaloblastic anemia, yes, patient has macrocytes, the MCV is going to 112, 120. Along with that, when you get the detailed history, the B12 levels are 2000. I don't think physiologically this is possible, but I don't consider it is a wrong report. No, that is not a laboratory error. But if you go into the details, these patients have been invariably injected with B12. I don't know what is the concept of majority of the clinicians in spite of repeated warning given to them that if you want to assess the anemia, please don't give blood transfusion or any treatment. Get the investigation done and then go for bone marrow. And most of the time, this megaloblastic anemia in the bone marrow is frank one. And most of the juniors, they hesitate. How is it possible that the B12 level are 2000? Not possible. Give it. Patients need treatment. Similarly, this has been found in iron deficiency anemia. They give injectable iron, then send for the iron studies, and they turn out to be normal. So now, even the investigations which you are getting along with the bone marrow, you have to take them as 100% reality with a pinch of salt. This is my advice to you. Okay. Now these are the miscellaneous conditions, not very specific, but there are many articles on this. That is CBU histocytes, yes, you do see in the bone marrow, they are non-specific, not diagnostic of any specific conditions. Gaucher cells and Niemann-Pick, as far as Gaucher is concerned, yes, we did not have a single case of bone marrow. We have a Niemann-Pick here and you will be seeing, but that's why I have not kept a photograph of Gauchers here. Okay? Then metastatic carcinoma, yes, clustering of the cells are common, and yes, leishmaniasis you will be watching here. Okay? Now, others are the osteoclasts. Sometimes, yes, you see osteoclasts and then you have to presume whether they are, basically sometimes they are very small, so whether they are plasma cells, because mostly the cytoplasm is bluish. But sometimes staining is so bad that the plasma cells also show pink cytoplasm. and very difficult to diagnose. I can say that I cannot vouch and say these are the osteoclasts. But if the cells are not fitting in typical morphology of megaloblast or this, then I call them this. Okay? Then plasma cells. Again, sometimes these plasma cells is a problem. Atypical plasma cell can give rise to problem in identification, but overall increase in plasma cells, yes, you can count them in that. Otherwise, sometimes it is counted as a blast cell also. Okay? Mast cells and yes, emperipolysis is many times seen, mostly in infectious condition.